Good afternoon, everyone. I want to welcome you to today's webinar. Before we begin, we have a few housekeeping rules to discuss. Please, everyone, mute your line. I've kind of taken care of that on the back end, but if you become unmuted, please mute yourself. You can use the chat box to ask questions. All the questions will be answered at the end of the presentation. For any additional questions not answered during the webinar, you can email us at education@nola.gov, and there are no CEUs offered for this webinar today. Now you'll hear from Dr. Regal, who will introduce today's speaker.
Thank you, Astacia. Welcome, everybody. We're so excited to have our speaker today, Dr. Nancy Hinkle. She's a professor of veterinary entomology at the Department of Entomology at the University of Georgia. So it's wonderful to have her here. So Dr. Hinkle received her BS and MS in medical entomology from Auburn University and her PhD in urban entomology from the University of Florida. And she actually worked on cat fleas. She then served on the entomology faculty at the University of California for about 10 years, and then she joined University of Georgia Department of Entomology in 2001. I know she's the author of many scientific and technical articles, mostly on fleas and ticks and bird mites and flies as well. And just as a side note, I called her during Hurricane Ida, actually right after Hurricane Ida, to get some advice on some fly issues that we were having here in New Orleans. So it is my pleasure today to turn it over to Dr. Nancy Hinkle, where today she's going to talk about delusionary parasitosis. I think this is something that everyone in our industry encounters, and so I'm very much looking forward to her presentation today. Dr. Hinkle?
Thank you, Claudia. It's really a comment, unfortunately, that we do have to deal with invisible bugs, and vector control should never be faced with this. But unfortunately, I'm sure that many people have run into this. And be patient with me again.
Appreciate it. I know there's a lot of people on the line. This is going to be recorded, by the way. If there's a way that you could actually turn off your camera, I think it'll be a little bit less distracting. Appreciate that your mute is there, but if you could just please, yeah, that would be great. So that way we can focus on the slides. Please use the chat, all right? Stacy and I are going to be monitoring the chat throughout the presentation, and we're going to be asking those questions at the end. All right, so Dr. Hinkle is getting her presentation up and running. It's a challenge always to use these platforms.
Do you see that now?
I think it's coming up. So let's see here. It went blank for a minute, so I think that's a good thing. So let's see. Actually, it's not coming up. Oh, here we go. Yep, I got it. Okay, very good.
Okay, thank you so much. I do appreciate your allowing me to be with you today. But as I said, it's a shame that we have to talk about this. This is a medical issue. This is not vector control. And I realize that there's a variety of people attending today, but I'm going to be talking mainly to vector control because I know you folks are the front line. And those of you in pest management of any type, you're out there on the front. You're dealing with the people who have these problems. And frankly, I'm pretty sure that every time you go to a party and you mention what you do for a living, somebody's going to come up to you and say, well, look, I've got this bite here. What did this? So that's the way I'm going to be looking at you folks having to deal with this condition. Have you ever had someone send you a box of Ziploc bags? If not, please send me your contact information and I will be glad to forward a few. This is what I get. Now, as Claudia said, I am a veterinary entomologist. I work on pests of animals. I really am not interested in pests of people. But unfortunately, I'm the person in the department who gets stuck dealing with invisible bugs. I've been doing this for over 30 years now. I started when I was a graduate student. For some reason, I found it fascinating at that point. Now, not so much. It's lost its novelty, I guess. But anyway, this is what we get frequently. I'm dealing with about 4 or 5 cases of invisible bugs every week now. It used to be 4 or 5 a month, and now it's down to just about 1 a day. And that's a lot of time, as you can appreciate, people calling, people emailing, people sending me pictures of their putative bugs and so on. Now, I want to mention what delusory parasitosis is, and it has a lot of different names. Delusions of parasitosis, delusion of infestation, Ekbom syndrome, and so on. I'll probably generally call it delusory parasitosis or something like that, but these are all names for the same condition, and that's the delusion that one's body is infested with invisible bugs. And I want to make the point that these people are not malingering. They're not doing this to get out of work. They are not pretending, and they're not imagining it. This is their reality. They are just as convinced that they have bugs in their skin as you are that you're sitting in that chair right now.
Miss
This is,
Nancy,
yes.
the slides aren't advancing.
Uh-oh.
So we'll try. Yeah, they're not going forward.
Okay, let's go back and see if we can get some way. All right. Stacy, are you seeing them advance now?
No, ma'am.
Okay.
It's okay.
Yeah.
This has been bandwidth, so everybody on the line, just bear with us, please.
Please. Oh.
It just worked a few minutes ago, so.
Yeah.
All right. Are you able to move it, or did everybody see it advance?
I will have her unshare her. Okay, now it's advancing.
And
now
you're seeing, are you seeing just the slide now?
Yeah, so we're at number 2, and there must be some setting. So there's a few people that are saying that they can advance the slide, so just bear with us. We want to make sure that Dr. Hinkle moves them. Yeah, so are you missing, Dr. Hinkle, are you able to advance it?
Which slide are you seeing now?
I'm seeing slide 2.
Okay. Now what?
Uh-oh.
Now I see slide 3.
How about you, Claudia, and everybody else?
I see slide 2. Oh, no.
Dear.
All right, I think you may have to go out and then reshare your screen. Let's try it again.
Okay.
All right, thanks everybody. Thanks for being, patient. I know everyone's chatting. We're gonna go ahead and just redo it.
No, that's not what I want.
Center.
Okay, how do I do that then, Claudia?
Well, let me see. Is everybody see slide 3? Are you able to see slide 3, Nancy?
Yeah, that's what I've got up.
Okay, great. So let's try it again. So we're getting lots of yeses on the line. So let's see if you can move to 4 real quick.
Okay.
Aha, I think we got it.
Okay.
All right, sync to presenter. Yep, that works. Thanks, everybody.
Thanks for letting me know. I didn't want to go through the whole thing with people being.
Appreciate it. Awesome. Okay, great.
So I'm going to go back and just make the point that entomophobia, arachnophobia are not the same as delusions of parasitosis. Those are true fears. Those are phobias. That's a condition where someone has an unreasonable fear that makes them actually ill when they are exposed to insects or spiders. But now we're going to go and talk about another condition that's confused with this, unfortunately. That's Morgellons, and it's also known as the fiber disease. Now, hopefully you won't run into this, but if you do, it's another thing on the spectrum, probably, of people who think that their bodies are infested with something that they can't see. If you're interested, there was actually a paper published a few years back, several years back now, where the Centers for Disease Control actually investigated this condition and came to the conclusion that it was not a valid medical condition. So again, Ekbom syndrome, we use that term because it's less stigmatizing. Ekbom syndrome is the clinical term for this condition. As you can imagine, saying delusory is kind of, well, stigmatizing. It's kind of insulting to people that you've got a delusion. People don't want to be told that they're dealing with a mental or psychological problem. But again, this is a condition in which the individual considers himself to be infested with invisible bugs. And this individual shown here in this photograph had been sending us specimens for quite a while. He take his pocket knife and dig holes into his skin, and then he would gouge out the tissue and send it to me, and I'd put it under the microscope and never find anything except gobbets of tissue that he had extracted from his body. So those lesions that you see there, the holes you see in the skin, the scars you see, were all created by him attempting to remove his putative bugs, and there were no bugs there. So this is an example of delusory parasitosis. Now, before I go any further, I want to define the term infestation. If you are covered with mosquitoes, 50 or 100 mosquitoes are sucking your blood all at the same time, you don't say that you're infested with mosquitoes. Even your people there that you're visiting and you're trying to kill their mosquitoes in their neighborhoods, they don't say they're infested with mosquitoes. They say they're being tormented by mosquitoes. They've got mosquitoes attacking them and their families. So what is an infestation? Well, this is when a population of some organism lives in or on the host. They feed on the host, they reproduce on the host, and they sustain the population over time on the host. So that's what a true infestation is. And again, back to delusory parasitosis, Ekbom syndrome. This is an erroneous, unshakable belief that the skin is infested with a parasite. So that's people claiming that they have an infestation, a parasite living in or on them. Now, what is a delusion? A delusion is a false belief. It's not consistent with the patient's intelligence, their educational level, or their cultural background, and that cannot be corrected by reasoning. And I know it's purely human nature for all of us to say, if I just explained it better, this person would understand that it's a delusion, it's not real. You cannot. There's not enough data, there are not enough publications. You are not persuasive enough to change a delusion. This is a mental health problem. Now, I deal with animals, as I said, and probably the reason that I get so many of these cases is that people think they get their infestation from an animal, usually a pet or some animal in the neighborhood, just some animal. So these, for example, my dog had another lime dip bath last week, and he seems to be much better. I think once the dog is fine, my cure will come fast. Yeah. The dog sleeps in between the living and dining areas, and I think he is the reason we are still battling this. I do not believe my living areas are infested any longer, just me and dog, and I think we are almost free. So don't give up on the ozone treatment. Some people use ozone generators to eliminate their supposed infestation. We do not recommend that, by the way. And then some people use, there's a food grade diatomaceous earth DE that you can put on your animals. Diatomaceous earth should never be used on a living animal. Diatomaceous earth, as you know, is an absorbent. It will absorb all the oils out of your skin. If you've ever worked with it in your garden, for instance, you get it on your skin, it sucks the oil out and your hands get all dry and cracked. Same thing if you put it on your dog. It cracks the poor animal's skin, dries it up, and they itch worse because now they've got dry skin. So diatomaceous earth should never be used on a dog or any other animal. I think the dog and I keep contaminating each other, trying to break the cycle, but it makes me sad, but I may have to give up the dog in order to achieve this cure. He is great for about 2 days after the sulfur dip, then starts the itching and biting again. By the way, I contacted the vet and simply stated to me that dog mites will not infect humans. Not only is the human medical field ill-advised, so is the veterinary field. I don't understand how the medical professionals never contract this nightmare. Making a very good point there. With all these people going to doctors over and over again, you would think the doctors sooner or later would get infested with these invisible bugs as well, but they don't. So that seems to indicate that whatever this is probably not contagious. And this is one reason that I'm distressed about this condition. I'm an animal lover, and I hate to think of animals being put down just because they've got a deluded owner. So if the owner thinks that the dog is infested, the owner can have the animal euthanized, and that disturbs me. So What do people blame their invisible bugs or call their invisible bugs? Well, most people, as you know, don't know that much about insects. And so they have only a few that they can attribute their supposed infestation to. Some of the most common ones are springtails, no-see-ums, bed bugs, and bird mites. And there's reasons for this, but none of them are justifiable. Let me mention that if you're not aware of it, there was a fascinating study done by researchers at North Carolina State University. And they did a survey where they went through homes and they checked carefully. They got down on their hands and knees and crawled around on the carpet and they collected every arthropod they found, every spider, every bug, every insect that they could find. And then they quantified this and they found in 100% of the houses that they looked, they found cobweb spiders. In 100% of the houses they sampled, they found book lice. By the way, the book lice is that tiny little speck in between the prongs there. This is in a notebook, so you can get an appreciation for how tiny book lice are. By the way, book lice are not related to the lice that suck blood and live on humans. Book lice feed only on the fungal growth that we get on mildew and things like that that grow on books and magazines that are stored for long periods. So this is probably why book lice are so common. In my storage room, I've got lots of cardboard boxes full of old magazines, and book lice just thrive there, especially here in the heat and humidity of the South. Gall midges. Gall midges were found in 100% of the homes that they sampled. Now, gall midges are completely innocuous little creatures. They're tiny, they're fragile, they're frail, they're not strong flyers. So they are attracted to lights at night. So I'm guessing that the way they end up in our homes is they fly to the lights, the porch lights at night, and then when we open the door, the inrushing air just sucks them on into the house, and they're again too frail to fly against it. So that's my guess on why gall midges end up in the house. They can't bite, they can't sting, they're perfectly harmless, but there's a lot of them in people's homes apparently. Ants, I don't think anyone will be surprised to find that every home sampled has ants in it. And fungus gnats, you probably run into this a lot. Here in the South, when people bring their plants in at the end of the summer, they bring in the potted plants and then they start overwatering them, and fungus gnat larvae live on the fungal growth that occurs in the soil. So we need to let our indoor plants dry out. At least the surface of the soil should get dry before we water anymore. That's better for the plants as well, and that will also cut down on the number of fungus gnats that are flying around in our home. So completely harmless. Again, the larvae feed only on fungus. The adults don't feed, so they're just flying around desperately trying to find a way to get out of our houses. And carpet beetles. Everybody has carpet beetles in their house. Every time you shed hair or you have a pet that sheds hair that collects in the corner somewhere, carpet beetles thrive on that. That's what carpet beetle larvae feed on. So they feed on hair, and they've always got plenty to live on. So they do really well living in our homes. So that's an indication that these people suffering from invisible bugs will not have any trouble finding bugs to show you in their home. They've all got something living with them in their house and they can bring it in as a sample, but that doesn't mean it's what's infesting them. So keep an open mind, but also be skeptical. There's another great study out there. This was done in Australia. A medical entomology lab kept records for 30 years of all the specimens that were brought in. And there's the list of the top 6 things. Their main tick was the #1 specimen that was submitted. Bird mites, interestingly, were the second most common arthropod submitted. Bed bugs, moth flies, and we've all run into moth flies in public restrooms, those tiny little flies that look kind of like little bitty moths, actually. They do really well in the drains in restrooms, so that's probably why we see so many there. Head lice were the #5, and pubic lice, interestingly, were #6. So also note that of all the samples submitted over those 30 years, 21% contain no evidence of any arthropod at all. So it's not just here in North America where we're having cases of invisible bugs. 1 in 5 of the specimens that were submitted to this medical entomology laboratory were not arthropods either. So they have problems with invisible bugs as well. Springtails. There's actually a long story about why springtails get attributed as being the invisible bugs. They are not, they cannot live on human bodies. They do not bite, they do not sting. They, again, feed on fungus, fungal spores, so they're harmless, but they have a bad rap, unfortunately. And there was a paper published that we wish had never gotten out in the literature, but unfortunately people online find it, and then they find it as justification for their belief that they're infested with springtails, with columbella. And no-see-ums, that's another thing that people with invisible bugs call their little pests. They think they must be no-see-ums. Since the person is unable to see what's biting them, it must be a no-see-um. Of course, no-see-ums are actually biting midges. They're very small bloodsuckers, like tiny little mosquitoes. And again, they behave like mosquitoes in that they come in, they take a blood meal, and then they fly away. Biting midges never enter homes. So if someone's complaining of being bitten indoors, it is not a biting midge. And then bed bugs. Everybody's heard of bed bugs now, so they figure if they're infested, it must be bed bugs that are infesting them. Well, as you know, bed bugs do not infest humans. In fact, they're so fragile that they really spend very little time on the host. What they do is they wait until we're sound asleep, so we're going to be still for a while, and then they surreptitiously sneak up on us. They insert their mouth parts, they take a blood meal, and then as soon as they're through feeding, they scurry away and hide someplace safe, because if we perchance rolled over on them, we would rupture them and they would die. So they're really much more vulnerable than we give them credit for, but they don't infest humans. And bird mites. Oh my goodness, if you run out of things to do someday, Google bird mites, because they now have the reputation of having evolved so that they can live on mammals, especially humans. And this is not true. Bird mites are specifically feeding on avians. They feed only on birds. They cannot feed on mammals. They cannot live on mammals. And we humans, being mammals, cannot serve as host for bird mites. So despite all the claims online, and as you know, anybody can say anything they want to on the web, bird mites do not infest humans. Now, bird mites will try to feed on people. So if you're involved in a case of putative bird mites, if you need to survey for them, I would recommend using a glue board, put them down in areas where the home occupants are complaining about being attacked by mites. And then remember that because mites cannot fly, they don't have wings, when you look at the glue board, you don't have to look all over the glue surface. You only have to look around the margins, because again, these arthropods are unable to fly. So once they get to the edge of the glue, they get stuck and they can't go any farther. So it really makes it a little simpler to monitor for them. Bird mites, again, are not invisible. You can see them with the naked eye. I've been working with bird mites on birds for over 30 years now. I've been covered in bird mites. Yes, they will bite. They will attempt to feed on a human, but their little mouth parts can't get deep enough to get blood from us. They're going to starve if they get on a mammal. They can only live on birds. We run into them a lot on commercial chickens. So if you've got backyard chickens, you very well may have bird mites, and yes, they may get off and get on you and attempt to feed, and it's annoying. You feel them puncturing your skin, and it's discomforting, but they cannot live on you. If they can't get back to a bird, they're going to starve to death. And as I mentioned, citizens assume that anything that bites is in the purview of vector control. So if they're getting attacked by something, they bring their problem to you because you're the expert. They expect you to solve their problems. Yeah, ticks and mosquitoes, that makes sense, but invisible bugs? So how do we identify Ekbom syndrome sufferers, people suffering from invisible bugs or delusory parasitosis? Well, you can almost always count on them bringing you samples. And we used to call this the matchbox sign, because people would take a little piece of tissue and they'd wrap up their samples and they'd stick them in the matchbox and bring them to us that way. These days, most of the samples that I get look more like this. And yes, this is one sample from one person. This individual was determined to prove to me that she was infested with invisible bugs. So she sent samples in Altoid boxes and prescription vials and water bottles. She wanted to be sure that she got a good sample that she could prove to me that she was infested with invisible bugs. Well, you can appreciate how long it took to look through all these samples. And there were no arthropods, no insects or mites in any of these samples. This is what we saw when we put the material under the microscope. Not surprisingly, skin that cracked off, dried blood, some scabs, that sort of stuff. Nothing interesting, nothing that indicated that there were any arthropods, any insects or mites involved at all. Now, this case was, I guess, to me different, but in many ways it was all the same. This lady had been sending us samples for several months, and she lives in Georgia, and so she was not getting the results that she wanted. I had not confirmed for her that there were any arthropods involved, but she was absolutely convinced that she was infested with bugs, and she was removing samples to send to me. So you can see some of the damage that she had done to her skin in acquiring these samples. Well, one afternoon, she and her sister drove over to the campus, to Athens, to see if they could meet with me in person. And she was going to show me her bugs and convince me that, yes, she did have bugs, even though I had not been able to find them in any of the samples that she had submitted. So she came to campus. I don't allow people to come and visit my lab with their invisible bugs. For one thing, I'm not a medical doctor. I am not authorized, and I'm not the least bit inclined to examine people's bodies. I don't want to see the body. This tells me nothing. Just collect the bug, send it to me. I'll put it under the scope, and then I can tell you what the problem is and make recommendations about what to do about it. But this lady was convinced that she needed to argue her case in person. So she came over and she started asking around where Dr. Hinkle's office was, and a helpful little freshman said, "Oh, I know where Dr. Hinkle's office is. I'll take you there." So they showed up at my office door, and well, what do I do now? So I took them down to the laboratory, and we set up the microscope, and I told her, "Okay, now show me the bugs." So she reached into her purse and she pulled out a Ziploc bag, and then she extracted a pair of tweezers and she started to pull scabs off her skin. I said, "Whoa, what are you doing? Don't do that." And her sister looked over at me and nodded and said, "Yes, this is what she does after dinner every night. She sits down in her lounge chair and she pulls off all the scabs." And obviously, she's been doing this for quite a while. You can see the scars, and she's going to have these for the rest of her life. Well, not surprisingly, there weren't any bugs in any of the lesions, but as you can see, some of them are quite deep. You could actually see tissue down in some of them. She had made some pretty impressive holes in her skin. I think what disturbs me about this case, one of the things that disturbs me, is that this lady is a registered nurse. She's trained in medicine. She knows better. Intellectually, she knows that there are no invisible bugs that can infest a human body. And yet, at the same time, in her heart of hearts, she is convinced that she herself is infested with invisible bugs. Now, a little background on this lady. In addition to being a registered nurse, she's married. Unfortunately, her husband had recently been involved in a major automobile accident. He was hospitalized in another state, going through rehab. So she was the sole support of the family at the time. She had two teenage kids. You can imagine the drama going on in the household. Her daughter's best friend had recently been kicked out of her house because her parents didn't get along with her, and so she had moved in with this family, with this lady as well. So she had three teenagers in the household. So there was a lot going on. And again, she was the only one working, so she was responsible for keeping everything going, trying to see after her husband's recovery from a long distance, and dealing with all the hassles of having a bunch of teenagers running around the house. So she had a lot on her. And I'll mention this later, but we conjecture that stress can bring on these sorts of cases. So for some reason, some people are predisposed to develop delusions, and some kind of stressful event in their lives like this might be what, I guess, breaks the camel's back and brings on these sorts of symptoms. I want to make the point that this is not an unusual condition. It's actually the most common delusional disorder, with probably more than 250,000 cases in the United States at any given time. So don't be surprised that these people find you. There are a lot of them out there. Now, one of the weirdest things about this condition is that it's not unusual for more than one person in a group or a family to be affected. And we're talking again about a psychological condition. So, how can it be, quote, contagious? Well, I'm not sure. I'm not a psychiatrist, so I don't understand what's going on here, but this is well known. It's actually published in the medical literature. There's a technical term for it, folie à deux. And this is where entire families or entire offices can be experiencing this condition. So you may run into this. A lot of people in pest control do run into this, where a whole office full of people will swear that they're being attacked by invisible bugs. That is hard to explain. I've rationalized it to myself that if you're sitting next to someone who 8 hours a day is talking about their invisible bugs, you may be cynical for a while, but after a while, you just hear invisible bug, invisible bug, invisible bug. And if you have any sensation on your skin whatsoever, your brain can't help but thinking, well, maybe I have those invisible bugs. It's intriguing. I don't know how to explain it, but it's a phenomenon that has been observed, and we certainly encounter it ourselves. Now, these are the sorts of emails that I get. This is just an example. Dr. Hinkle, I have been suffering from what feels like insect bites at night, but can't ever see any insects where affected. Every so often, I think I see something flying past me, but have still never found one. I used a fogger for my apartment, and while it seemed to work for a few days, the culprit is back in full force. I also just recently returned from being out of town for 4 days, thinking the lack of a blood source would starve whatever it is, but it only seemed to make them hungrier. I feel like they're crawling on me, followed by an intense sting, itch, bite, then a little welt forms that, when scratched, turns into a scab that doesn't heal quickly, as in 1 to 2 weeks before they finally go away, the scab. Nothing I've found on the web has been helpful in pinpointing what I'm dealing with, and I was hoping you might be able to steer me in the right direction for relief. Now, as you can imagine, every one of these cases is different, and yet there seem to be themes that run through many of them. For instance, what I've highlighted here in yellow, I can't ever see any insects. So these people, most of them claim they're invisible. Some people claim that they can see them, but no one else can. So again, they must be practically invisible. And then this culprit is back in full force. I'll mention this again later, but it does seem that some things that these people try work temporarily, but nothing works effectively for very long. So the pest never goes away, and that's something we've seen dealing with these cases. These people keep coming back month after month, sometimes year after year. And frankly, even when they give up on me, frequently I get feedback from my colleagues in other states or other agencies that say, yeah, we've got the same lady now we're dealing with, or she's sending us samples. So they never give up. They are determined to find someone who will validate their delusion. And I also mentioned there in the last paragraph, this crawling. This is the first sensation that people describe for us. They may mention later that they itch or they feel a stinging sensation, but almost all of them, the first thing they say is, I feel something crawling on me. So that's just some common features that we see in a lot of these cases. Now, there are lots of other attributes that we'll mention later on, but that's just to give an illustration of how there are many commonalities in these cases. And I also must mention this. I remember when I gave you the definition, I said that it has nothing to do with intelligence or education. No one is immune from being susceptible to delusions. This is a case that was actually published by an entomologist, Dr. J. Traver. She was a well-respected entomologist back in the middle of the last century, did good science, very intelligent, but she lived for over 30 years thinking that she herself was infested with invisible bugs. She actually found a mite and she named it and she described it. And it wasn't until several decades later that an acarologist, a mite specialist, was looking through this paper and realized that what she was showing was actually just the common house dust mite. So it wasn't something she was infested with, it was just a common contaminant. As you know, here in the Southeast, house dust mites are everywhere. They're in our beds, they're in our furniture, they're in our everywhere, in a carpet. So it's not surprising that she found house dust mites. They're everywhere. She probably just got one from the bedding when she got up that morning and happened to find it that day and put it under a microscope, and that's what convinced her that she was infested with that mite. But of course, there was nothing really infesting her. And again, she suffered from that condition for over 30 years until she actually died. Well, as I've indicated, we're getting a lot of these cases, and we can't do anything for these people. This is not an entomological problem. This is a psychological problem. It can be treated. It can be treated with medication, and people can get their lives back. But because they are convinced that their problem is bugs, they are unwilling to even consider any kind of mental health intervention. But since we're getting these cases, we're getting a lot of information from these people, we thought, well, at least we'll start trying to get some baseline information that we can pass along to the medical profession. So when they deal with these cases, they'll have a better feel for what these people are experiencing. So we're trying to quantify demographics, symptomatology, management behaviors, medical histories, and comorbidities. And so what have we found? Well, just to summarize, so far, we have confirmed, as Dr. Ekbom indicated, that this condition is most common in the elderly. So people over the age 65, 70, certainly as they age, it's more common. And the sufferers are disproportionately female. We're getting about 2 females for every male, and we don't know why this is. Is this condition actually more common in females? Or is it that women are more likely to admit to having this condition than men are, or men less likely to complain? We don't know, but these are the numbers that we're getting in our experience. These people exhibit a variety of self-destructive behaviors. If they're employed, they frequently will quit their jobs. And there's probably a couple of reasons for this. One is that they feel a moral responsibility not to pass along this infestation to other people. So they don't want to be around people and risk someone else getting infested. And then secondly, they're spending so much time every day trying to get rid of the bugs that they don't have time to hold down a job anymore. So they end up unemployed. They exhibit obsessive laundering and cleaning. They spend pretty much the whole day trying to get rid of the bugs in their home, on their clothing, on all of their belongings. And this pretty well takes over their lives. Now, when they first start out, they're able to compartmentalize this condition. So they are able to have a life and keep a job. But then eventually it seems that this condition overwhelms them, takes over, and occupies essentially their entire lives. In an attempt to get rid of these creatures infesting their furniture, they will burn or destroy the furniture. They don't want to give away the furniture because, again, that might risk infesting someone else. And again, they feel some moral, ethical responsibility not to risk that. They also exhibit repeated pesticide misuse and abuse. They will use just about any insecticide they can get their hands on. They, of course, are not restricted by any label information, so they'll use just as much as they want to, wherever they want to, whenever they want to. And yes, they will also apply insecticides, including agricultural and household insecticides, to their bodies. They use all sorts of home remedies, and there's no rhyme or reason for why they come up with theories as to what will work against these pests. Just the weirdest things out there. Aloe vera is very common, tea tree oil, because it cures everything. So we hear these themes over and over again. If they can't get rid of the infestation in their living quarters, they eventually will abandon the home. They end up living with family or friends. You can imagine how that goes over. Again, these are people who are spending 24 hours a day trying to get rid of bugs and talking about their invisible bugs. So they don't make the most pleasant roommates. And so eventually they end up living, they have to go to a hotel. They use up all their life savings. The only thing they end up owning is their automobile. And so we've actually had quite a few people who are reduced to living in their automobile. That's the only thing they have left in this world. As you've seen from some of the pictures, they will exhibit self-mutilation, excoriation, trying to dig the bugs out of their skin. And as I alluded, they are very willing to provide us with specimens, but of course these turn out to be just gobbets of tissue and other debris that they can collect around the house. And as I indicated by that study done at NC State, there are plenty of arthropods around the house. If they go around and dust out the windowsills, they can come up with all sorts of creatures, none of which, of course, can infest human bodies. And amazingly, even though they claim these creatures are invisible or so tiny you can barely see them, they can provide elaborate descriptions of the pest and its life cycle. Frequently, they will tell us when the eggs are laid. Oh, this creature lays its eggs in my nose and they hatch on Tuesday afternoon and they get into my bloodstream and they come out my skin on Friday afternoon and they fly around the house and they mate, and then the female flies back and lays her eggs in my nose, and they start out orange and they turn green and then they lose their wings and then they're purple or something just incredible. So it makes for entertaining stories, but it has no basis in biology. And as I said, if you go up to somebody's house and you see rolls of carpeting out front, this may be people trying to get rid of their invisible bugs because they assume their environment's infested. They rip out their carpet and they discard their household belongings. Now, admittedly, people with bed bugs frequently get rid of the carpet because they think the carpet's infested with bed bugs, but this is not an unusual phenomenon at all. And other aspects of this, these people frequently experience social isolation, and usually this is of their own choice. Most of these people, as I said, are concerned about infesting other people, and they certainly don't want to pass along the infestation to their families, their children, their grandchildren. Some of the saddest situations are grandparents that haven't seen their grandchildren in over a decade. They're just unwilling to let anyone near them. And as has been alluded, several of you already know this, we usually find that the onset of this condition has been precipitated or preceded at least by some major life event. This could be a divorce, could be a death in the family, losing a job, something that's a major emotional trauma for this individual. And then soon thereafter, they start noticing that something's attacking them, and then they hit this spiral um, of infestation and seem never to get out of it. By the time they reach us, they have consulted several physicians, usually quite a few, and these can be general practitioners, they can be dermatologists, allergists, all sorts of specialists, and they're usually quite disgusted with physicians by the time we hear from them because they haven't gotten the answer that they want. The physicians may say things like, well, obviously that's a bug bite. Call your pest control company. Or the physician may say, well, that must be scabies. Here, put this on it. So put this cream on your rash and you'll be fine next week. And none of these have worked, and they don't feel like their physicians are hearing them. So they're pretty aggravated by the time we hear from them. When we do hear from them, generally the minimum duration of what they've been experiencing has been 3 years. Now remember, they don't get better just because we see them. There's nothing I can do for these people, but that means that they have suffered for 3 years before I even hear about them. So don't be surprised if when these people come to you, they've already been through a variety of doctors, they've done a variety of things to their home, to their skin, and they've suffered for quite a long time. They generally, as I said, start off complaining about this crawling sensation, but they may also mention things like stinging, biting, and itching sensations. But think about it, the skin's really rather limited in what it can feel, or at least what we can call these feelings. And I don't know how to say this most emphatically, but they are adamant that it's an infestation. They will not consider any other explanation. They don't think it's an allergy. They don't think it's a response to medication. They are convinced they have bugs in their skin. And if you contradict them, that's not going to work out well, because they have made their minds up. And they generally use the term desperation. If my phone rings and I answer the phone and the first sentence I hear is, "Dr. Hinkle, you have to help me, I'm desperate," I have a pretty good idea of where that conversation is going, because these people are desperate. Again, they've been suffering for 3 years or more. They have no indication that there's any end in sight. And so they truly are desperate. Now, I know people with a lot of pest problems are upset, very concerned, people with bed bugs particularly. But even people with bed bugs don't often use the word desperate. And as I mentioned before, the delusion is frequently shared by someone else, the folie à deux that we mentioned earlier. And as I said, these people will treat themselves with all sorts of things: alcohol, peroxide, vinegar, chlorine, Clorox, bleaches, gasoline, kerosene. So if they didn't have a skin problem to begin with, they certainly will after they've administered these things to their skin. And again, they take their furniture out back and set it afire, throw it away, rip out the carpet, spend all their time cleaning. So these people have a very focused life, a very narrowed focused life, I would say. And again, the cause of delusory parasitosis is not known. Medical doctors really are not working on this. Psychiatrists, of course, never see these people because, as I said, these people don't go to psychiatrists. They're convinced they have bugs, and they are not interested in people playing around with their heads. So I have some theories about what might be causing this, but remember, you're hearing from an entomologist, so don't believe anything I say. I have no validity when I'm talking about psychological or medical conditions. I'm an entomologist. But if you ever read the package inserts on some of the medications, that little, the insert that has so much writing and it's in such small font, of the top 10 medications that are prescribed in the United States, look at the potential side effects. All except one have hallucinations as a potential side effect. Paresthesia is that creepy crawly sensation on your skin. Most of them have that. Pruritus is itching. So perhaps what we're seeing is a manifestation of reactions to medications. Again, this is purely a theory from an entomologist. It may have nothing to do with it, but this would perhaps explain why it's so prevalent among the elderly. Older people, of course, take more prescription medications. Paresthesia and hallucinations are common side effects of OxyContin, and certainly we've had an overuse of this drug in our society in the last couple of decades. Recreational drugs, cocaine and meth, are both known to have side effects that produce sensations in the skin and the illusion that something's emerging from the skin. In fact, in the medical literature, they are called cocaine bugs and meth mites. So people who use cocaine may be seeing bugs emerging from their skin. People with meth addictions may think that they've got mites crawling around under their skin. That's certainly a good reason not to use illegal drugs. It's not rare, apparently. There's actually advertisements showing that picking for bugs under your skin isn't normal, but on meth it is. So these people have worse problems than invisible bugs, obviously, but it would certainly be an argument against using illegal drugs. This illustrates here, this patient complained of a worm infestation in his neck. He used a pair of scissors to excise the imagined worms. So these people have some serious problems. You won't be surprised to hear that the toxicology screening of this patient was positive for cocaine, opiates, and tranquilizers. So drug use may explain some of the cases that we run across. We don't know. We don't know. And then because it's more common in the elderly, we might want to consider psychological causes. Certainly as we age, stress, anxiety, depression become more prevalent. We're losing autonomy. Our lives are being constricted. We've got physical pain, mental anxiety, and so on. So maybe psychological causes can be attributed to the incidence of delusory parasitosis. So what do you do? What in your position? How do you deal with this? Well, I recommend that we stick to the principles of integrated pest management. And the first indication in integrated pest management is identify the pest. So do your job, find out what we're talking about. Sample, monitor, look at the samples that are provided by the individual and explain to the individual that no recommendations can be made and no treatments applied until the pest is identified. And if we don't find a pest, we don't make any insecticide applications, no recommendations. But we do know that if something's attacking a person's body, it's a medical condition. And so we can say, you need to consult a physician. Now, don't be surprised if they come back at you and say, I've been to a dozen doctors and none of them will do me any good. They don't know what they're talking about. But there's nothing we can do. This is not an entomological or a pest management issue. If I want to look at samples, what I recommend is that they carry around a roll of clear tape, and when they feel the sensation, they apply it to the area, and logically anything that's in that area will become locked into the mucilage on the adhesive tape. Then they box these up and ship them to me. I put them under the microscope. I can see through the tape and find out if there's any arthropods, and I don't find arthropods. What I do find are bits and pieces of debris. So these are up in the upper left-hand corners, a piece of carpet fiber. The rest are just scabs and hair and other debris that you would find on a human body. Nothing unusual there. Now, some people say, well, how about if we just spray and tell the person that we've sprayed, we've gotten rid of the pests, and maybe the psychological issues will be addressed and they'll think that we've gotten rid of the bugs. Well, the placebo effect does work, but be warned that there's always regression, that these bugs are going to come back. So this is a danger. If you start out treating for non-existent bugs and they keep coming back, how are you going to know when to stop treating for the non-existent bugs? I think this is an ethical consideration as well. And even though you will find information on the web about black pepper mites, there is no such thing. You will find references to paper mites on the web. There are no such thing. No mites have wings, so there are no flying mites. Nevertheless, these people will claim that they can see mites flying around in shafts of sunlight coming through the window. Well, motes of dust are not at all uncommon. We've run into them. I don't know why these people are convinced that these have now turned into bugs. So to cut to the chase, there really are only two arthropods that infest human bodies. These are lice and scabies mites. These are the only arthropods that infest humans. They are strictly human pests. You only get them from another infested human. So there's no role for pest management or entomology to play, or vector control to play in dealing with these. These are strictly medical conditions. They must be treated medically. And I'm kind of cheating here because, of course, there's three species of human lice: pubic lice, head lice, and body lice. But again, just human lice and scabies mites. That's really the only things that can infest a body. So there's no insect or mite that can live in the environment and then switch to infesting the human body. So if people say there's something coming out of my sofa and infesting my body, can't happen. No insect or mite can feed on inorganic material, so they can't live on steel or aluminum or nylon, so they cannot survive on furniture or carpeting and then move to infesting a body. No winged insects infest human bodies, so if they see something flying out of their body, it's not biologically possible. No invisible mites or insects infest human bodies. In fact, there are no invisible mites or insects. Yes, there are microscopic ones, but they're not invisible. No external animal parasites can infest humans. Now, notice that I said external animal parasites, so you don't have to worry about getting lice or mites or fleas or any other arthropod from another animal. You can, however, get internal parasites from other animals, so never ever eat feces from any animal. Bird mites cannot infest humans, that's just fact. And human body infestation is a medical condition and must be treated by a physician. There's no role for pest management to play. So what is your role? Well, you determine if insects or mites are involved. If you don't find any, then recommend that the sufferer consult a physician. And remember, it is unproductive to tell the individual that they need mental health evaluation. Just don't mention psych, don't mention mental, don't mention anything like that. That's going beyond our area of expertise. I would ask that you don't call the wounds bites, because unless you know mouth parts have penetrated the skin, you don't know it's a bite. So don't confirm what the individual suspects. Remember, you're the expert. Don't believe everything the caller says, even though Ms. Smith is looking at you so pitifully and saying, "Why won't you help me?" Remind them that a pesticide can be recommended only when a target pest has been identified, and if they claim that their body's infested, it constitutes a medical condition and should be referred to a physician. Now, we can't refer people, but they should see a physician. I want to mention this lady here. She was convinced that she had a worm in her jaw, her cheek, and she was determined to prove it to me. So she indicated that she sent this picture showing that when she put peroxide on the area of her cheek, she could drive out the worm's eggs. That's what that white frothy material there is. That's worm eggs. And she was actually able to extract the worm and prove it to me that she was infested with a worm in her cheek. Well, obviously, that's not really a worm. She has succeeded in removing the subcutaneous fatty tissue that underlies all of our skin. And once she's done this, she's done some significant damage to her face, and she's not going to be able to repair that. As you can see in this picture, she's wearing very heavy makeup trying to cover up the damage that she's done, but she's going to have a scar there, unfortunately. So that illustrates that these people are seriously suffering. I take their suffering seriously. I don't mean to make light of it. It's stressful, but this is a medical condition. And you're right, most doctors don't deal with this, and they are eager to get these people out of their offices. And that's probably why a lot of physicians are more than willing to just say, well, obviously you've got an insect problem, call your pest control company or call vector control. Nothing we can do about that, unfortunately, but we cannot take on something that we are not trained or equipped to deal with. This is not entomology. This is mental health. So I recommend that we continue to insist that these people see a physician, not a mental health specialist, but a physician, and a medical doctor should refer these people for treatment for a mental health problem. So delusions of infestation or delusory parasitosis is a medical condition. These people must get into the medical system to ever have any hope of getting the medications that they need to get their lives back. There's my contact information, insects@uga.edu. If you want to follow up, I'll be glad to chat with you. I'd love to hear your stories. And if you've got any questions, I think we have a half a minute now. Thanks so much for your attention.
Thank you so much, Dr. Hinkle. This is, I don't know what to say. It's really a challenge, and you're right. I mean, so many of these cases are, Dr. Catone just mentioned, they're just heartbreaking.
Mm-hmm.
We often, at the City of New Orleans, many of the pest control companies and other folks, they'll send, people to us. And so it's always a fine line of making sure that there really isn't an issue, but it's just a challenge, for sure. All right, so I think I'm going to put a Stacy on the line here. I think we do have some comments and some questions that are coming up. So I'm going to kick it over to her here to answer some of these questions. But we did have a question here. If you'll have access to this recording, yes. So we will eventually post it on our website. But follow us. You can always email us at education@nola.gov. And we'll help you there with that situation. All right, Astacia, you want to go ahead and take it? So I believe we do have questions. Please put them in the chat, if you do have questions. And we do thank you so much, Dr. Hinkle, for your time today.
No,
all right,
my pleasure.
Astacia.
Okay, the first is a comment. It says, I have found that there is usually a trigger that starts this condition, an actual infestation of some kind, not usually a parasite on skin, but something that creates fear and revulsion. And I've had cases that take some time to prove that there's nothing there. I have had success in this, but as Dr. Hinkle notes, it's not always easy. Always start by empathy for the situation. I have felt great satisfaction when I've helped people in this. So that was just a comment about what you were saying, Dr. Hinkle.
Excellent comment. Yes. And that's a very good point that we need to maintain our empathy for these people. Yes.
Okay, and someone else commented, I often refer the individual to a tropical disease specialist.
That's another physician that's qualified to deal with. Yes.
Okay, and then here's a question. What about bat bugs? They do bite humans sometimes.
That's right. Just like bed bugs do. But again, they don't infest people. So again, IPM, we get in there, we sample, we monitor, we determine, we inspect, see if we find bat bugs. And certainly if we do, we treat for bat bugs, but we don't treat the body. We don't treat for invisible bugs.
Okay, here's
I
another
actually have,
comment. Oh, go ahead, Claudia.
I
Sorry.
actually have a question as well. So, do you know if there's any research sort of in the mental health arena um, to really start dealing with the situation?
Well, the short answer is no, because these people never go to a mental health specialist. They have bug problems, according to them, their view of the world. And that's something I wish we could find a way to transition these people to the specialists that can actually help them. But I don't have referral privileges for a mental health clinic. There's just no way to get these people to, and they are very resistant. And that's why I never use the term mental health or psychological. These people need to start out with a general practitioner or their family physician who should recognize this condition and pass them along to the appropriate specialist. Unfortunately, that is not happening.
Yeah, the next comment says that I have found that most physicians are really not well versed in this area. I have had cases in which a doctor saying that there is a bite in absence of an actual evidence that reinforces the delusion. It's too bad that they don't use entomologists to investigate in order to help address the problem, the real problem, or the delusion.
I concur fully. Very well put. Yes, it is frustrating.
Okay, these cases are heartbreaking. Have you noticed a change in the frequency of DP cases during the pandemic with masking, quarantines, etc.?
Very good point. Actually, we were talking with Dr. Claudia and Stacia yesterday about this, and I think several other people have mentioned this, that with people being quarantined, being confined, getting cabin fever, restrictions, the stress and anxiety of a pandemic, I think this probably has precipitated more cases.
Okay. How do you communicate with those that have seen medical providers, for example, dermatologists, PCPs, that tried empiric treatment, which doesn't work, but seems to exacerbate the problem by further convincing them that they are infested?
My short answer is not well. I don't respond at all well to these situations because I find it insulting that our medical professionals are not taking on the challenge of dealing with this medical condition. I don't know what to do about it, but it disturbs me greatly.
How do mental health providers deal with this problem?
There are medications. If you can get the person, the sufferer, to a mental health professional and they trust the mental health professional, there are prescription medications. The individual usually has to take them for a couple of months at least to get a blood titer that's sufficient to get response. And unfortunately, if you're familiar with mental illness, things like schizophrenia, these people are suffering, but they are unwilling to take medications. They're suspicious, they're paranoid, they're unlikely to follow through on a course of therapy. And that's the frustration. If they will accept the treatment, they can get better, they can get their lives back. But most of them are unwilling to, number one, go to a mental health specialist to begin with. And then, secondly, if they do, they generally don't follow through with the recommendations.
Thank you. The next comment is, I think one needs to be sensitive and not refer to people exhibiting mental health challenges and not to call them crazies.
Correct. And as I said, I never use the word crazy around them, and I never use the word psychological or psychiatrist. They're not crazy. They are suffering from a delusion. And this delusion is treatable. It's actually quite easily treated. They just need to get to the right specialist and be willing to accept the treatment. But as you, if you run into people with paranoia, they think everybody's against them, and the last thing they're going to do is put something in their body that they think may may fool with their brain.
Okay, to what extent do you believe bed bugs could be considered a threat to public health, considering they do not transmit disease to humans?
Oh, that's an interesting question. Yeah, it kind of depends on our definition of public health, doesn't it? But it does contribute to mental stress, anxiety, so it certainly has a role to play.
Okay, and we had a few comments that said this presentation should be made available to physicians to bridge the gap.
Well, thank you. We actually have been making this effort. There's another entomologist on this program with Dr. Gail Ridge, who has a lot of experience in this as well. And I encourage you to check up on her publications and the information she's putting out. She's actually putting together a book on this condition. So maybe eventually we'll make some headway into the medical world, and these people will get exposed to the physicians that can do something for them. Thank you. Thank you for that comment.
All right, Dr. Hinkle, thank you so much for taking the time. If we did not address your question, you can email it to education@nola.gov, and we'll make sure to get it to Dr. Hinkle. So I think Stacy is going to wrap it up.
Yep, just I want to thank everybody, especially Dr. Hinkle, for today's webinar. Claudia said you can email us if you have any suggestions for webinars or any future topics you would like to hear. Please email us at education@nola.gov. We will be putting this on our website. We recorded the presentation, so it can be shared with others. And we also just want to mention that we have coming up is our new urban rodent series. Part 2 is February 3rd at 2 p.m. and we'll be speaking about integrated rodent management. You can register via emailing us at education@nola.gov or putting a comment in the chat that you want to be added to that list.
Oh, I think all right. All right. Thank you, everybody. Enjoy the rest of your day. Thanks, Dr. Hinkle.
Thank you. Stacia, is it possible to capture all of these comments? I'm not following the chat, but if you can save those, I would love to see a transcript of those. These people are raising some excellent points.
Okay, and there was one, I see that there a few more questions that came in maybe while we were doing the ending. It says, when the DP client has convinced other residents in the home of the problem, including children, at what point should we pursue further action?
Ooh, I'm afraid that's above my pay grade. I'm concerned about that as well. You know, my philosophy is if you're an adult, you can do pretty much anything you want to your body. You know, it's yours, it's your right. But imposing this on a child, that really distresses me. I don't want that to happen, and I don't know what to do about it. Maybe Child Protective Services should be, yeah. Gail Ridge is saying contact Child Protective Services. I think if it gets to that point where the parent's inflicting, you know, actual damage on the child, then maybe we need to step in. But I feel the same way about animals. When you're inflicting damage on an animal, someone needs to intervene as well.
And then someone asked, do you know if doctors get any training on this subject?
Short answer is no. And for that reason, I make a conscientious effort to introduce the topic to my pre-med students here at the University of Georgia. I think every pre-med student should be aware of this. They're going to run into it. And I want them to start doing something for these people. Once they get into practice, they need to be responsible. The Hippocratic Oath, everybody thinks that the doctor is going to do what's best for you, but unfortunately, a lot of people are falling through the cracks, at least in this area.
Okay, I'm checking just for any last comments and questions that may have come in.
Okay.
If I see anything. Someone commented, "Thank you for your presentation. It was very interesting. I remember having to read a play called Bug for a
Oh,
winter course
excellent.
of college
Yes.
that dealt with this condition, and it was adapted to a movie."
Yeah, that's right. Uh-huh.
And then someone is asking, is there a book devoted to this topic?
Not currently, but as I said, Dr. Ridge is putting together one. There are articles out there. If you want to just Google Delusory Parasitosis, there are quite a few articles out there.
Okay. Someone says they have found a number of pre-med students who have experienced DI patients.
Oh, again, I expect medical professionals are going to run into this frequently. Yeah.
And we have another comment. I've had that issue with the elderly grandmother who
Oh,
had 14-year-old convinced that she had the same issues. It was heartbreaking. So it seems like a lot of people in the webinar have had experience with this issue.
oh my goodness. That really brings it home, doesn't it?
Yeah. Okay, I think that's it. I don't see anybody typing right now. So it might be all for the questions.
Well, if you come up with more, Stacia, feel free to follow to email them to me. I'll be glad to follow up. I'm
Okay,
just glad people are interested.
will do.
Very good.
All right, thank
And
you for
also for the
joining.
people,
Yeah.
I think, Stacia, there's a bunch of people who wanted to be added to our distribution email list, especially
Yes.
because of the rodent control. So please, I put it in the chat, email education@nola.gov. Send us your contact information and we'll make sure that you're notified on all of our training. We have some really good stuff coming up.
Sounds like it. Yeah.
All right. Thanks so much, Nancy. We'll do a download of the chat for you to review. And thank you, everybody, for taking the time to join us this afternoon. Have a great day.
Thank you so much. I
Thank
appreciate
you.
it.
Bye.
Take care. Bye.